It's time for another warm-up. Let's get going. Which artery supplies each of the following regions? So what is the artery of the foregut? That's going to be the celiac artery. The artery of the midgut, that's going to be the superior mesenteric artery. And the artery of the rectum and the distal third of the colon, that's going to be the inferior mesenteric artery. Next, what disorder is characterized by an excess of gastrin? So that's going to be the Zollinger-Ellison syndrome. Next question. In Langerhans cell histiocytosis, electron microscopy of a dendritic cell would show what characteristic finding? So the classic feature is the Birbeck granules. On electron microscopy, these Birbeck granules give the appearance of kind of a tennis racket. All right, that's it for the warm-up. Let's get to that lecture now.
Over the years, I've gotten a reputation for using food in my lectures. All right, let's go ahead and work through the end of session quiz. Cornerstone of any nutritious breakfast. So somebody thought it would be funny to assign me the video on eating disorders, which is fine, whatever. Who cares if I'm being typecast? No, it's fine. So let's start with a patient profile. This patient profile is called Hungry for Honors. A 24-year-old female medical student comes to the emergency department after vomiting blood. She's been unable to find time to exercise and follow a healthy diet while studying intensely for upcoming exams. Sound familiar? And she's been inducing vomiting to prevent weight gain. The patient frequently eats excessive amounts of food and feels guilty about it afterward. The patient has successfully hidden these eating binges from her roommate. The patient complains that med school is making her fat, and she worries that she'll be too fat to be the maid of honor at her sister's upcoming wedding. The patient's height is 67 inches, her weight is 150 pounds, and her BMI is 23.5. She's well-nourished, well-developed, and in no acute distress. Her oral mucosa is slightly dry. The parotid glands are enlarged and tender. And the remainder of the physical exam is unremarkable. So what electrolyte abnormalities and acid-base disorder would be most likely present due to her recurrent induced vomiting? So let's talk about the three main eating disorders: anorexia nervosa, bulimia nervosa, and binge eating disorder. Let's decide on a diagnosis, and then we'll come back and talk about the electrolyte and acid-base problems associated with this. So when we hear eating disorder, the first thing most of us think about is anorexia nervosa, although actually anorexia is probably the least common of these three. So the diagnosis of anorexia nervosa has three main components. So first of all, these patients have a distorted body image. They think of themselves as obese when they really aren't. They also have an intense fear of gaining weight. And the other key component is that they reduce caloric intake relative to their energy requirements in order to lose the weight that they think they need to lose. So they'll actually refuse to maintain a normal body weight. Now, there are lots of ways they can achieve this. Excessive dieting and refusing to eat is the classic way. Possibly excessive exercising, 3 or 4 hours a day, every single day. Possibly they have low body weight because of purging. So remember, all that purges is not necessarily bulimia. Patients with anorexia nervosa can purge as well. Eating disorders are more common in women than in men across the board. On social history, these women and girls are often very high achieving and they care a lot about what people think about them. As the BMI gets very low, these patients may develop secondary amenorrhea. And other clinical features might include decreased bone density and osteoporosis because they have inadequate intake of calcium. They may have electrolyte disturbances, especially hypophosphatemia, low phosphate, which may require a nutritionist to help correct. And also look for symptoms of depression, which is commonly comorbid with anorexia nervosa. In some ways, it's helpful if this coexists with depression because anorexia is very hard to treat, but if there's depression you can treat, sometimes this will also treat the anorexia. Now, having said that, how do we treat anorexia? Basically, it's just supportive therapy, nutritional education, and also cognitive behavioral therapy and counseling. Unfortunately, medications like SSRIs don't typically work well for anorexia by itself, but sometimes treating any depressive symptoms will indirectly help to treat the anorexia. Now let's talk about bulimia nervosa, which is actually a little more common than anorexia nervosa. Bulimia is characterized by episodes of binge eating, so inappropriate, high-calorie intake within a short amount of time, which the patient perceives as uncontrollable. And then the binge eating episodes are followed by some type of inappropriate, unhealthy, compensatory behavior to prevent weight gain. Now this is usually purging with vomiting or using laxatives to induce diarrhea, but it could also be episodes of strict calorie restriction or episodes of intense exercise, just like with anorexics. Now the binge eating could be a matter of eating faster than normal, eating until the patient is uncomfortably full, eating large amounts even when they aren't particularly hungry, eating alone because they're embarrassed about how much they eat, and feeling guilty or disgusted about it after the fact. Bulimic patients still have an unhealthy preoccupation with their weight, but unlike anorexic patients, bulimics generally maintain body weight within the normal range. So they are getting some nutrients, they don't have such a distorted body image. On physical exam, if the patient is inducing vomiting, you may see something called a Russell's sign, which is abrasions or scars or calluses on the knuckles or the back of the hand from inducing vomiting by sticking a finger down the throat, and then when they gag, they injure their skin with their teeth. They may have erosion of the tooth enamel from the gastric acid, or enlarged parotid glands from parotid inflammation due to all the vomiting. Then on the labs, these patients may have elevated serum amylase, also due to parotid gland inflammation. Then one quick note about treatment. Although medications are not particularly helpful for anorexia nervosa, SSRIs like fluoxetine have shown some efficacy with bulimia, especially fluoxetine when combined with psychotherapy. Then the third eating disorder I want to review is binge eating disorder, which shares some important features with bulimia, but it's clearly different. These patients have episodes of binge eating, just like in bulimia, on average at least once a week for at least 3 months. But unlike bulimia, patients with binge eating disorder do not engage in those inappropriate compensatory behaviors such as purging. So while patients with bulimia will tend to maintain a healthy weight, patients with binge eating disorder tend to become obese. These eating binges are an expression of deeper psychological problems. These patients often have very negative feelings towards food, but the binge eating kind of soothes them in some way. They may not like to eat, they just can't help themselves. They feel compelled to eat, out of control. So let's go back to our patient profile. This patient is binging, and then she's purging by inducing vomiting. So because she's purging, we know this can't be binge eating disorder. And she's clearly preoccupied with her weight. She may have a distorted body image. She calls herself fat, even though her BMI is 23.5, which is in the healthy normal range. And her weight's probably pretty appropriate for her height. But because she's maintaining a normal weight, you can pretty much rule out a diagnosis of anorexia nervosa. So this patient most likely has bulimia nervosa. So what kind of electrolyte and acid-base disturbances will this patient's purging put her at risk for? Well, the answer is hypokalemic, hypochloremic metabolic alkalosis. Hypokalemic, hypochloremic metabolic alkalosis. So let's talk through that. Remember from GI that when the proton pump on the gastric parietal cells generates hydrochloric acid, it puts a little bit of bicarb into the serum to buffer the gastric acid that's eventually going to be reabsorbed. But then when you vomit, that hydrochloric acid never gets reabsorbed. It goes from the stomach into the toilet or the trash can or wherever. So the stomach is putting some bicarbonate into the serum, and that bicarb is never going to get buffered with the acid. And the serum becomes slightly alkalotic over time. You can kind of think of it as the body's losing acid over time. The body is therefore becoming alkalotic. And then what happens to your serum chloride when you're vomiting up hydrochloric acid all the time? Well, chloride is going to decrease also. So these patients who purge through vomiting may become hypochloremic. And also remember that our cells have a hydrogen-potassium countertransporter, which is involved in pumping hydrogen and potassium in opposite directions. So when there's alkalosis and the serum hydrogen is low, this hydrogen-potassium countertransporter is going to be pushing hydrogen ions into the serum to balance the pH. At the same time, it's pulling potassium out of the serum into the cells in order to maintain electrochemical neutrality. So pulling potassium out of the serum leads to hypokalemia. So you put all that together and you have a hypokalemic, hypochloremic metabolic alkalosis. And you can see that in purging or any type of chronic recurrent vomiting. All right, now let's go ahead and take a look at the end of session quiz. All right, first question. What are the diagnostic characteristics of anorexia nervosa? So you have distorted body image, intense fear of gaining weight, and reduced caloric intake relative to energy requirements. And all this results in a low body weight. Next, What are the diagnostic characteristics of binge eating disorder? So with binge eating disorder, you have episodes of binge eating with a sense of lack of control, and then you have no compensatory behavior to offset the increased caloric intake, which means these patients tend to be obese. And the next question, what are the diagnostic characteristics of bulimia nervosa? So here you have episodes of binge eating again, and here you have the inappropriate compensatory behavior. So these patients will often maintain a normal body weight. And the last question, one more time, what electrolyte changes are seen in patients with excessive vomiting over time? Hypokalemic, hypochloremic, metabolic alkalosis. And we also have one rapid fire fact. The most common class of medications for bulimia nervosa is the SSRIs, such as fluoxetine. All right, that's it for eating disorders. I'll see you next time.